So this is our case.
Okay. This is a case of 66-year-old male gentleman, smoker, hypertensive and dyslipidemic, presented with recurrent episodes of chest pain, rest angina since 7 days. ECG showed ST elevation in one in AVL. Troponin was elevated and ECG showed an echo showed hypokinemia of lateral wall with ejection fraction 45%. Next slide, please. Slide, please. Patient was loaded with ecosprin 300 mg and Brilinta 180 mg. His lab parameter was within normal limit.
Okay. So this is the history. Patient had some acute chest pain 7 days back, possibly acute coronary syndrome and then ongoing angina. His LV function is more or less maintained. So should we run the angiogram for you?
Yes. Now, after the angiogram, maybe there will be something from the panel.
Yes. So I think just the angiogram shots. Please show the angiogram shots. So this is the left-sided angiogram. The right coronary artery was fine, so we are not showing that. So this is next one, ariocaudal, and then the AP cranial view. Next one, show all the shots. Okay, next. Okay, next. Next. Yes. So this is the angiogram in front of you. I think let's have a discussion with the panel.
Now, I think the symptom is due to circumflex lesion.
Obviously, obviously.
What is your plan? First circumflex or the bifurcation?
No, he had acute coronary syndrome from circumflex about a week back. So we are planning to fix the circumflex, which we have already done. Since there was a lot of waiting involved, so we have done the circumflex, and now we are showing you the bifurcation LAD, how to deal with that. So if you are okay with this, can we show the circumflex stenting?
Yes.
Okay, just go ahead. So there was some difficulty in wiring. We had to take a hydrophilic wire, pre-dilated with 2 and then 2.5 millimeter of balloon. Next. And then put a stent. We have used a NeoFlex. So from Biosensors, this is a Biometrics NeoFlex stent, which is a biodegradable polymer. So 3 into 14 and post-dilated. So result looks pretty okay with circumflex. Okay, now come next. Now if you notice very carefully, LAD in the proximal segment also has a tight lesion which is eccentric, which is not actually visible in AP cranial view. Just look adjacent to the septal artery. So it's a tight lesion and a concentric calcification also. So that's the reason we have done a IVUS prior. We run the IVUS images for you. Next. And obviously there is a lesion just distal to the very big diagonal in the LAD also. Next. So this is the IVUS. Please run the IVUS. Can you have a look at the IVUS?
Yes, we can see it.
Yeah. See, there is a lot of calcium, it's concentric plaque. Again, the calcium content is high. And we are just arriving at that septal. This is the one. This is the one. So clearly, LAD is ischemic, and we are planning to do the bifurcation lesion. We have to come across the very big diagonal. It's a longish LAD lesion starting with the septal, which is eccentric one, as I mentioned, and it's very clear on the IVUS also. And then just adjacent to the diagonal, just distal to the diagonal, and there is still a lesion about 15 millimeters from the diagonal origin, which is again looks significant. Yes, patient had acute coronary syndrome. It was thrombotic lesion. So I agree there is some distal embolization which is leading to the spasm of the distal vessel. So we planned access stent, which is a dedicated bifurcation stent. Since I believe whichever strategy we choose for a bifurcation lesion, there are many lacunas still. So we are right here while the deployment of access is going on. Can you just zoom here? Please zoom on my hand. So while we went ahead with access stent down into the LAD, we started opening the access stent slowly. So this is the console. We have to be very slow in trying to deploy the stent and retrieve this marker. So while we do that, and until the time we reach the point of no return. So if you can look at the cine, I'm just giving you a cine. We are right there at the point of no return. Just give a check. Okay. So can you have a look?
Yes, we see it.
Okay. So while we come to this level, we have to give a small thrust to the whole device so that it takes the shape. The part of it goes into the LAD and part of it goes into the diagonal. And if you see the three markers, which are distal markers of this access stent, the one marker has come into the LAD and two markers into the diagonal. So this is a very precise deployment, and now we can deploy it fully. But while you do that, I think keep the distal thrust on. So I'm just maintaining some distal thrust on the device, distal push, and while retrieving this, okay, now it is deployed.
Oh, it's very nice.
Just
Do you have a risk for distal injury
No.
while pushing a little bit?
No. A small push, a very gentle push that fits the bifurcation of this device into the real carina. So that is a very important step while deploying this access stent. And if you see, we have done it precisely, and I'll just show you after I retrieve this device. Now it's pretty well indicated, but once we have to use this access stent, it's a slightly bulky one. We should prepare the bed thoroughly, and it's recommended that pre-dilatation should be done with almost 1:1 ratio of arteries to balloon. So if it's a 3 millimeter vessel, at least 2.75 or 3 millimeter balloon is required to aggressively pre-dilate the bed. Now since there was a lot of calcium, we decided we go ahead with the cutting balloon to prepare the bed and then go ahead with the deployment of access.
It seems very good. Maybe there is a radiolucent area in LAD distal to stent, but it's because of the device, I think.
It's wonderfully, the carina is taken care in a best possible way. The part of the stent is in the diagonal and part is in the LAD. In this specific case, we have to use extension in the LAD beyond this stent because there is a lesion there. That looks like a only drawback with this device because we may have to use the multiple number of stents. But otherwise, this is the best possible way to restore the carina and take care of the bifurcation.
Because it's nearly dual LAD, isn't it?
Yes, it is. That is the reason we chose this, because we were not comfortable jailing the diagonal with a single stent, possible tap or then culotte. I think all these are good, but in some way or the other we jeopardize the side branch. Also, I think if you notice, the diagonal wire is jailed, but it's a self-expanding device, so there is no real issue with the jailing of the wire behind the stent. It easily comes out, and then we can rewire the diagonal if we think that there is something to be done with the diagonal ostium or or the middle of the vessel, there is some lesion in that. But otherwise, we don't require to rewire the side branch, and then we go as per plan into the main LED. So this, I'm taking out the wire. This come out nicely. We don't require to rewire the diagonal, since there was some issue with the carinal shift after the pre-dilatation, and that has been taken care by this access stent.
When you put an extra stent in LED, does it affect the design of the first stent?
Pardon?
The extra stent now, you will
No,
implant
no,
in
no,
LED.
no. We'll just show to you. Give us 2 minutes. We'll show you overlapping stent with this access stent in the distal LED. Give me stent Zines Expedition 2.75 into 24, 23?
For the distal lesion, maybe IVUS can be done.
For the LED distal, I think we have done the IVUS prior, and it shows it's a significant lesion, and anatomically also it looks a significant LED lesion. I think it has to be handled. We can't have this outflow obstruction just at the distal edge of the stent. So now if you see that the calcium just at the bifurcation point is still some work needs to be done within that access stent. So it has to be dilated, post-dilated aggressively at that point. And as per recommendation, now this is a 3.5 into 14 access stent. As per recommendation, we can go up by 0.5 size, so we can go up to 4. So we can have a aggressive dilatation there. So this is the extension which I am going ahead into the distal LED. It's not a problem crossing the axis. It's fully deployed, it's self-expanding one. And then overlapping is also not a problem because the markers are pretty well visible. Check. See? So this is a good overlapping at this point. I can still come back a little bit. Okay.
In such cases, when the distal balloon protrudes a little bit more proximal, and after then, do you need to have a kissing balloon for the bifurcation?
See, usually this stent takes the good shape into the side branch ostium also. But yes, if there are issue, it's very, very easy. You can take the two balloons. We have to rewire the branch. That's the only issue. But it's pretty easy.
Leave the wire, so it will complicate also.
So this is the distal stent deploy.
One
Now look
more
at this.
From the panel.
Look at this. There's still some work required within the access stent. There's some residual at that lesion point in distal LED. So we'll do that, and we can keep discussing if you want to discuss about this stent any further. As far as kissing is concerned, I think it's not an issue.
It seems perfect, Dr. Kapoor. Thank you for your successful case. But one more contribution maybe from the panel.
Dr. Kapoor,
Yeah.
before deploying this access stent, bifurcation dedicated
3.5.
stent, do you do in every case IVUS and the balloon beforehand, or do you have some other type of lesion types that you directly try to implant this stent?
No, see, if we are planning this device, this implant, the bulky, which is slightly bulky one, as per recommendation, we should aggressively pre-dilate. That's the reason we decided first 2.5 and then 2.75 cutting balloon. So otherwise, this may give a problem in pushability. We may not be able to deliver this access stent, but if we are not planning this and we're planning one stent strategy with a possible tap, I think we can go ahead with the normal protocol, dilate with 2 millimeter balloon and go ahead with stenting, and then take care of the side branch with some kissing balloon dilatations.
Thank you very much. And now we are in the end of the session. If you have some comments, Dr. Kapoor, we can hear it. And thank you also for your
See,
success.
firstly, we are highly grateful, highly thankful to the organizers for keeping us engaged for all these consecutive 4 years.